To finish off the semester in obesity and weight management, we're going to take a look at obesity pharmacotherapy. Usually when people think of obesity management, they are focused on behavioral strategies that aim towards a caloric deficit and that promote fat mass loss and weight loss accordingly. But when individuals have developed obesity, especially higher levels of obesity, it's often not enough. It can often show small amounts of results. About 5 to 10% drop in body weight is quite typical with behavioral interventions, but some individuals need extra help, might need extra medical intervention, depending on what them and their doctor, healthcare practitioner thinks is best. So it used to be like a foundation of behavioral therapy is what we would use for obesity, and then maybe add in pharmacotherapy and bariatric surgery. But as far as these new guidelines on obesity management from that are published in the Canadian Medical Journal, medications, pharmacotherapy, are seen as part of an overall management plan for obesity, but really it's going to depend on the individual, what is best for them, and it's something that the individual with obesity plus their healthcare advisors and practitioners can decide on what is the best option for that person. Here in Canada, there are 3 drugs that are approved for obesity. They go by the commercial names of Saxenda, Xenical, and Contrave. There's a couple other that are approved within the United States by the FDA, but these are not available in Canada, though, there are some proponents here in Canada that believe that they should be, but that is neither here nor there. Okay, so I'm going to cover these 3 obesity drugs. We'll start with Orlistat, which was approved back in 1999. And I actually talk about Orlistat in my first year nutrition class when we talk about lipid digestion, because Orlistat blocks the activity of pancreatic lipase, so it is unable to help break down our lipids in our digestive tract, in our small intestine, into smaller components, into more of its base units that can then be absorbed. So if we can't break down lipids, we cannot absorb them. That's one of the primary concepts in digestion versus absorption. So these lipid masses stay larger, they're not absorbed, and because we're absorbing less lipids, we're also absorbing less calories. Okay, because every gram of lipid has about 9 kilocalories per gram. So we're effectively decreasing the total amount of calories that come into the body, not necessarily how many calories a person takes in. Okay, so this is really associated with the diet, so it's taken usually before or after meals or during meals, about 3 times a day is often how it's prescribed. One of the biggest issues with Orlistat is the digestive issues that can come up with it. Since you are blocking something that promotes lipid digestion, lipids aren't digested and they're not absorbed. So they have to come out somehow. And they come out through the stool, so that can lead to oily stools, higher risks of fecal incontinence as well, and some gastrointestinal issues. And that's one of the main reasons people discontinue the use of Orlistat, is these gastrointestinal issues. That said, one of the ways to reduce the amount of issues is to consume less lipids in the diet. If you're consuming less lipids, you're going to have fewer of these symptoms. Also really important with Orlistat or any kind of lipid blocker is if you're blocking lipid absorption, you're also decreasing the amount of fat-soluble vitamins A, D, E, and K, vitamins A, D, E, and K, that are absorbed along with lipids. Okay, so often we will prescribe vitamin supplements with individuals that are also taking Orlistat. Okay. The other common drug prescribed here in Canada for obesity is Laraglutide, or better known as Saxenda. It is a GLP-1 agonist. Almost said inhibitor. It's an agonist. We saw GLP-1 earlier. Remember, it is secreted by the small intestine, lower down in the small intestine, and it works both via its endocrine pathways as well as vagal afferents, basically towards our appetite centers. And it's one of those signals, GLP-1 is one of those signals that, hey, there's food in the small intestine, you can decrease hunger. That's basically what it's signaling. Okay, and it does through these appetite-related pathways. Liraglutide is prescribed for obesity, but it was originally prescribed for diabetes, type 2 diabetes specifically, and it is still prescribed for diabetes, but metformin is the leading diabetes drug, and that typically is prescribed more commonly for diabetes. So unsurprisingly, there are some positive effects of liraglutide that go beyond fat mass loss, and they are related to improved basically blood sugar handling. Okay, so this GLP-1 agonist also is shown to increase insulin, which of course we know decreases blood sugar. Also, there's a suppression of glucagon. Glucagon is kind of the opposite hormone to insulin, also secreted by the pancreas, and this one is involved with raising blood sugar. Okay, it also tends to slow gastric emptying. As we're going to see in the studies that we're going to look at in a moment, liraglutide promotes higher levels of weight loss compared to that lipase inhibitor, Orlastat. Okay, one of the biggest issues with liraglutide is the price, and the fact that the effects are only really seen when you take the drugs. So it's not something that, like, you know, someone might go on this drug and see really significant decreases in appetite and really improved, you know, blood glucose, etc. But this drug can be quite expensive, like thousands of dollars a year for a person, and people with lower socioeconomic status might find this drug quite prohibitive economically. And if you go off of it, let's say you take it for a while and you go off of it, those results aren't typically maintained. Okay, just like, you know, we're going to see this as a common theme, just like with Orlistat, but differently, we again see gastrointestinal side effects, more so around nausea and vomiting, but we can like play with the dosage, or a doctor could play with the dosage to see what's going to be best for that particular individual. Okay, so I wanted to look at this study that compared Orlistat and liraglutide, and really I wanted to highlight it because it gives you a glimpse into how some of these drug trials are run. Okay, and it also is a really good example of pretty good representation of data, which is something we talk about in this class. Okay, so all patients received lifestyle intervention, and notice that things kind of changed based on the time frame of the study. Okay, so people were randomized, about 500 people were randomized into one of these groups. Okay, so varying doses of liraglutide, placebo, or Orlistat. So remember green for Orlistat because that'll keep coming up. Okay, after about 20 weeks, notice there's fewer people at that time. There was an extension period. Okay, and then after year one, the liraglutide groups plus the placebo group were put into kind of a higher, or this liraglutide 2.4 milligram dose group, and then some of those people their dosage was upped as well. But really, more than anything, we're comparing liraglutide with Orlistat as far as its effect in addition to lifestyle intervention. Okay, so Orlistat, look for green. Okay, and then the bluish are those different levels of dosage of liraglutide. Okay, so you'll notice compared to the green, the higher doses, especially of liraglutide, promoted greater weight loss. When I look at the pooled group of Orlistat versus liraglutide, again, I see a significant increase in weight change. But still, we're looking at about 5 kilograms. So it's not like it's decent. It's about, 13 pounds if I have my conversions right. But it's not like going to fully change someone or fully have them drop, 50 or 60 pounds perhaps. Okay. We also saw an improvement in waist circumference, and the amount of people that showed a 5 or 10% weight loss was the highest again on those higher dosages of Saxenda liraglutide. Okay. And if I looked at the pool groups of liraglutide, again, there was a significant difference between the Orlistat groups and those liraglutide groups. Okay, we can look at this. This is a good example of above all else, show the data. So each of these points are where they measured the differences in weight. Okay, and again, we're measuring weight in kilograms on this. So what you're going to notice, so again, higher doses of liraglutide promoted higher amounts of weight loss, and especially compared to the orlistat group, and unsurprisingly, especially compared to the placebo. But then when I put the placebo group on the liraglutide, you'll notice their weight change mirrored that of the higher dosage of liraglutide group. If you got all that together. Okay. The other thing I wanted to highlight here, and this is very common, is you'll notice this big initial weight drop, and it kind of seems to taper out around the 6 to 7 month mark, actually, which is about here. 6 to 7 year mark, and you'll notice that often, and we see this with bariatric surgery as well, weight seems to like plateau as far as the weight loss goes, and we also see often a small increase after that maximal weight drop. Okay. In addition to the weight-associated outcomes of these drugs, there was also changes in a number of health-related outcomes. So, for instance, again, if I look at my Orlastat group, green, versus my pooled liraglutide group, I see a lower amount of individuals, and there's a significant difference here, that develop prediabetes. Unsurprising, since liraglutide is also an anti-diabetic drug. Okay. We didn't see a significant difference in metabolic syndrome between the pooled liraglutide and the orlistat group. We did see a higher decrease in triglycerides in the liraglutide group. We also saw a increase in HDL in the liraglutide group compared to the orlistat group at year 2. Okay. Also, we saw a significant difference in systolic blood pressure went down, not with diastolic, and a slight increase in pulse rate compared to the orlistat group in the liraglutide group. Okay, so in general, the health-related effects of liraglutide seem to be a bit more than with the orlistat group, but both have potentially positive effects on mean weight loss. Okay, but like I said, there are potential complications, and these are from that same study. So if I compare to placebo and I look at the varying doses of liraglutide compared to compared to orlistat, if I compare to placebo, even with placebo, we saw some gastrointestinal effects, but they seemed to increase at higher doses of liraglutide. Okay, and with orlistat as well. Okay, we saw higher risk of constipation, diarrhea, and nausea. Those were some common side effects. Okay, although the significance wasn't outlined on this graph. Okay, this chart. Okay, our third obesity medicine is Contrave. This is a more newly approved drug here in Canada. It was approved in 2018, the spring of 2018. And this one, again, like liraglutide, like Saxenda, same thing, is mainly works through appetite suppression. Okay, so this Contrave is a combination therapy of a drug called naltrexone and a drug called Bupropion. Okay, so naltrexone has historically been prescribed for alcohol and opioid dependencies, and we believe that part of its mechanism of action is in the modulation of those dopaminergic, wanting appetite pathways that are involved in more of the hedonic, non-homeostatic aspects of appetite. Okay, same kind of idea with Bupropion. This one was historically prescribed for depression and smoking cessation. And again, this one is believed to modulate the reward circuitry associated with food wanting, in addition to those homeostatic appetite-related pathways. Okay, so To be honest, they don't fully understand how this combination exactly works. They know, though, that it does work, but its exact mechanisms of action are still a matter of debate. But basically, appetite suppression is the main message here. So again, let's look at clinical trials and what they have shown. And again, it's good to see how data is represented. Plus, it's good to see how clinical drug trials can be potentially run. So it's a multi-clinic study at 34 US states, and they're comparing placebo to varying doses of naltrexone plus that bupropion. Okay, and like we see, compared to placebo, we see greater amounts of weight change. This is percent weight change from baseline, and we do see higher amounts. We have significance here, higher amounts of weight loss with those higher doses of naltrexone, and 32 milligrams is often what's prescribed. Again, it depends on that person and how their reactions are to it, but again, that's often how it's prescribed. You again see on this chart that around 6 to 7 months, that's when we start to see results tapering off. Okay. And that again is common with a lot of these drug-based interventions. But an 8% weight change, 8%, not 8 kilograms or 8 pounds, 8% is, as we talked about earlier, is enough of a drop in weight for someone with obesity to have a number of improved cardiovascular and other health outcomes. Okay. So unsurprisingly, because Contrave is associated with modulating appetite and decreasing appetite, when we asked people what their subjective experiences with various appetite factors were, we'll notice, especially at higher doses, green, of Contrave, we saw kind of more reduction in appetite. So how hungry have you felt? That decreased the most with the naltrexone 32 group. How full have you felt? How difficult has it been to control your eating? How difficult has it been to resist any food cravings? And again, these higher doses are the ones which were associated with the greater amount of that suppression. Okay, again, we're going to see some gastrointestinal effects with these anti-obesity drugs. That is the most common type of adverse effects. Nausea is one of the main things that comes up. It's often with like a lot of drugs, it's one of the main things that comes up. Okay. So I like this slide. This is from a 2020 review of current and upcoming anti-obesity drugs. So remember, like I said, this one is not yet available in Canada, or maybe ever available in Canada. The main ones that are liraglutide, Saxenda, as we talked about, naltrexone, bupropion. I can never say that word. This is the Contrave. This is Contrave, and this one, Orlistat, as we know. Okay, and just by eyeballing this, looking at various different obesity trials, we notice in general a little bit higher weight loss in the liraglutide group. Okay, but since they didn't put significance in here, it's hard to kind of compare these fully. But we do see a reduction as well, or similar reduction in that Contrave group, less so in the Orlastat group. Okay, I like this slide as well because it's another good example of, above all else, show the data, because they're showing the exact results. They're telling you, they're putting the number there, they're showing you the study period as well, so you can look at that. They're telling you your ends, and they're also telling you the drug dosage. There's a lot of data on this slide, and I think they did that pretty well. Okay. So I don't expect you to memorize this algorithm, but this kind of comes from that same study that last slide came from, and it just kind of shows some of the decision making that a doctor might use in order to decide on what medication is best based on what other things the patient has going on. Okay, and again, we would also want to pair any kind of prescription of medication along with lifestyle management as well. So it is clear that these obesity medications can have a significant impact on weight, but they also have a significant impact on a number of other health markers as well, significantly diabetes markers as well, especially Saxenda. Okay, that said, there is In Canada, zero public coverage, well, for most drugs. But even if we look at within the provinces, some provinces have drug plans, but there's zero public coverage for any of these three anti-obesity medications. Okay. That said, when it comes to diabetes medications, a larger amount of those obesity medications are covered. There are some private plans that do cover some of these anti-obesity drugs, but less than about 20%. And like I mentioned, some of these anti-obesity drugs can run a person $3,000, $4,000 a year. And this again speaks to how socioeconomic factors can impact how well a person is able to manage their obesity, right? Our options typically go up with the more money we have. It gave a C grade for federal coverage because there are some federal programs like the Public Service Healthcare Plan for federal employees, and I think the military as well. Yeah, the Canadian Forces also have health plans that cover this, but in general, no public coverage, and again, very minimal private coverage too. So again, there's three anti-obesity drugs that are approved for sale in Canada. There's Orlastat, there's Liraglutide, and then there's the naltrexone bupropion mixture Contrave. So Contrave, Saxenda, and Xenical, those are the three anti-obesity ones. Orlistat, this is the lipid lipase blocker, I should say, which restricts lipid absorption. The Saxenda Liraglutide, this is a GLP-1 agonist that works on appetite pathways. And then that Contrave drug, again, is working on appetite pathways, both homeostatic and non-homeostatic ones, and again, reduces obesity due to a reduction in appetite. Although Laraglotide also has insulin-associated properties too, as we saw. Okay. For the most part, these drugs are not covered by healthcare, and they probably are drug plans, and they probably won't be until obesity is more recognized as a disease. So although, we didn't talk about this, but although the Canadian Medical Association has recognized it as a disease, the provinces haven't. And if the provinces haven't recognized it as a disease, well, that impacts provincial healthcare. In Canada, healthcare is a provincial responsibility. The federal government gives money to the provinces, but the provinces decide on what to do with that money, right? And if we don't recognize obesity as a disease, then, that might limit the amount of options an individual with obesity has. And it's important to note that medication is not an option for everyone. First of all, there are side effects. There's economic reasons why it might not be, and some people might just not want to take medications, or they might have other kind of complications that make certain medications not appropriate. Okay, so again, this is a little bit more tailored to the medical management of obesity, but it's something that, if you're working with people with obesity, even with outside of a medical setting, it might be something that they just don't know exists. And, it might be something we inform them of if it seems appropriate. Okay, so that is pharmacotherapy for obesity in Canada. And in the next couple of modules, we are going to be looking at bariatric surgery as another part of the management system for obesity.